I did my minimally invasive surgery fellowship with a gentleman who was a general surgeon who trained, but then he went off and did a flexible endoscopy fellowship. This is back in the 80s, and so a long time ago, and actually was the first to develop a MIS fellowship. So when I went there, I did about 400 endoscopic procedures in advanced and not diagnostic stuff. So he does a lot of endoscopic surgery, and it was really amazing to me because I'm an old guy. So when I trained, we were still doing a lot of open surgery. So I went from open surgery to what I thought was going to be a laparoscopic fellowship, and it was, but I saw things I didn't even know could be done. We were ablating and resecting early cancers with an endoscope. And I was watching these patients go home same day, go to work the next day. And it really was pleasantly shocking, but also really motivated me to say, like, why aren't we all doing this? Like, why isn't this being offered everywhere? So I've tried my best to continue what he taught me. I do have some disclosures. None of these really will affect. I will be talking about some procedures where the devices are owned by the company. I do not personally benefit in any way from any kind of device being sold or anything like that. So, you know, if obviously you guys do a lot of bariatrics here, and so the SARS recently came out, kind of the, you know, we're all, if we're accredited, we keep a database for the MBS SQIP, and it basically tells you what your morbidity rate is. And we were happy to see that our morbidity rate for our bariatric cases is basically the same as cholecystectomy. So, you know, gastric bypass, even loop duodenal switch, which we do, has this kind of reputation as being complicated. And we don't see a lot of, maybe as many referrals or as quick referrals for these as we do for a cholecystectomy. And we get referred people who don't need their gallbladder out, and yet there are people that really need to have weight loss surgery and are not getting it. And so it's interesting. And the problem is perception. And the perception is not just on the patient side, but patients do have this perception that weight loss surgery is dangerous, that it's risky. But actually primary care physicians do as well. And I work for you know, a large healthcare system with a lot of PCPs. And so we sent a survey to all of them, asking them several questions about their perceptions of bariatric and weight loss surgery. We asked them about their knowledge in terms of what procedures are out there and what their concerns were about it, and when would they refer a patient to it. And we found some interesting things. I mean, less than half knew the NIH guidelines for weight loss surgery, and you know, almost a quarter reported concerns over complications, and a lot of people didn't even really know what options were out there. And by the way, if you don't know this already, a patient is 5 times more likely to have weight loss surgery if their primary care physician supports it. If their primary care physician, even if they think, I want to do this, if their primary care physician doesn't support it, they're not likely to go forward. And so we really have a perception problem with both patients, but also our referring doctors. And we need to fix that because, as you'll see in a minute, very few people actually have surgery that would benefit from it. Now, in 2013, Barham Abadaya, who's a gastroenterologist from Mayo Clinic, was the first to report a endoscopic sleeve. Okay, and basically what they did is they sutured from within the stomach, anterior to posterior wall in several rows, as you can see there. And it took a long time just because of the suture pattern, but it was successful, and the patient lost weight. And so there was some excitement about this potential of doing endoscopic weight loss surgery. And the thing that was exciting about it, and I didn't jump on it at first. As a surgeon, I was worried about sutures and the durability. I mean, we purposely do pyloric exclusions where we suture, you know, the distal stomach, and we expect that those sutures will come undone. And so I thought, well, this is probably not going to be durable. So I didn't jump on right away, but I started to see more and more places around the world doing it with very similar results. And this meta-analysis came out with over 2,000 patients with 11 different sites and showed very safe procedure, no mortalities, less than 1% serious adverse events. And actually the total body weight loss was pretty impressive. I mean, it was almost 20% at a year and a half, and the excess weight loss was on par with our surgical procedures. So I started to become interested in this now. And at the very least, I wanted to be at the table. So I really felt that, the surgeons who basically do bariatric surgery, we need to be at the table. If there's a new procedure coming, and we need to make sure that the studies are being done right, that we're looking at the right factors, that we're looking at things that we've already done for surgery for decades. And so I started to become interested and started performing the procedure in 2016. A few years later, I was approached about potentially joining a multi-center trial, randomized trial looking at endoscopic sleeve. There were 6 centers. It was kind of a well-designed study. There were 3 surgeons, 3 gastroenterologists. And basically, we wanted to confirm that these, basically retrospective data that we were seeing was really true. We wanted to be able to follow the patients a little bit longer. Bariatrics is hard. We don't always get the follow-up to know how patients are doing. And so for us to say that the weight loss is great, but not really have good follow-up, sometimes we have to be careful about those conclusions. But in this study, patients were paid, but they would only get paid if they did their 2-year follow-up. And so we had a very high follow-up, actually well over 90%. And Barham over at Mayo Clinic was one of the lead investigators with Eric Wilson, who's a surgeon at Texas. Obviously, we also wanted to look at secondary endpoints where patients, with hypertension, diabetes, hyperlipidemia, and other comorbidities, we wanted to see what the result was there. Basically, patients were randomized to either get the procedure or to have monthly counseling on diet and exercise with our weight loss team. It wasn't necessarily always a surgeon. Which is probably more appropriate, actually, more real life. But we had, the place had to identify whether it was an APN, dietitian, psychologist, or any of the above. And we followed these patients out for ethical reasons. Patients were allowed to cross over at a year. So if they were randomized to the diet and exercise group, they had the choice of getting the procedure at a year if they wanted to. And the results were pretty impressive, actually. It's better than what we thought. We had 49% excess body weight loss, which was about 32% more than the diet and exercise group. And our target was 25%, so we doubled that. We saw a 45% difference between excess weight loss compared to the diet and exercise group. We wanted just a 15% difference. 80% of patients achieved at least a 25% excess body weight loss. And there was about 16% total body weight loss for the responder group. And you can see that the red line is a crossover group. So at a year, the patients that crossed over actually got up to where our originally randomized patients were. So we were pretty excited about this. We also saw some expected findings here too. So metabolic syndrome, we saw 83% improvement. We only saw 35% improvement in the diet and exercise group. We saw improvement or resolution for diabetes and hypertension, and quality of life was significantly improved. And by the way, reflux was improved as well. Only subjective forms were sent, GERD HRQLs, but unlike a laparoscopic sleeve, if you're not familiar, which can cause GERD in a significant number of people, this actually improved GERD in a lot of patients. So it's given us a nice option in patients with reflux disease. And the complication rate was very low. Now, 2%, I will say, if you look at what the complications were, I would argue that we actually had less than 1% complications from a surgeon's point of view. So, there was one perigastric abscess that was just treated with antibiotics. The patient got an endoscopy, nothing was done. An upper GI bleed that didn't even require a transfusion. I know for bariatrics, that wouldn't even be considered a complication. There was one patient who was losing too much weight, but it was not due to the procedure itself. And so it was reversed. And by the way, that is something that patients like to hear, that this is a reversible procedure. There's still a lot of hesitation about permanently altering a stomach, but this, you can go in and cut the scar out, cut the sutures out if it's early, and it is a fully reversible procedure. So we have a procedure that has weight loss that's almost on par with surgery, with a complication rate that's lower. And patients actually were going home, same day. This is an outpatient procedure. We typically tell patients to go back to work, take maybe 2 days off and then get back to work. So there is some pain, but it's very minimal compared to surgery. This is just a short clip of what it looks like on the inside. So we're basically suturing, that's the anterior part of the stomach. We have a helix device that pulls in. This is a full thickness bite. That's very important. We need serosa to serosa in order to have any kind of durability. If you just suture mucosa, that will not last. And I will also tell you that the suture patterns have made a difference. So when we started doing this in 2016, we were taking just 3 bites, anterior, greater curve, posterior, and that was not a very durable suture pattern. What we've learned through bench type work is very simply, the more bites that you take on a single suture, then the more that the tension on those bites is spread out, and so the more durable the procedure. So we do what's called a U-stitch, where we start anterior, we go all the way to, greater curve posterior with several bites, and then we come back up, and then we suture it down. And that's kind of what you're seeing right here. So I think that's our last bite coming back around on the anterior side. And again, full thickness bites, which you can feel. The stomach serosa pops when you put the needle through. If we don't feel that pop, we actually will take another bite in that area, because again, mucosa will not, be a durable option. And if you followed along, or if you know anything about some of the endoscopic attempts in the past to do this type of surgery, a lot of the devices were mucosa based only, and it looked good when you were done, but it was not durable at all. So this is the first time that we've had a device that actually takes full thickness bites safely and is able to get something that looks like this. Okay. Now, this is what it looks like kind of on the outside. So you see kind of the helix device up there in the fundus, pulling in the stomach. And I think what's very important here is you see the device come through is that the needle device is going to come through, and this is a full thickness bite. Sometimes on the inside, it doesn't look like you're doing that much, but when you look at it from the outside, it's impressive. Now, having said that, this is surgery. It can be dangerous. So we're up there, as you know, near the spleen. I think us as surgeons, we have kind of this unique perspective where we can see that colon, spleen, other things are around that area. So we have to be a little bit careful. This actually is a different device than what I showed you, but it's very similar in that it's a full thickness device. So that's what the bite looks like, and then it'll be cinched. So this is kind of what it looks like 3 years later. So the sutures are kind of floating. The sutures are probably not contributing anymore, but because it was serosa to serosa, we have kind of a durable sleeve formation of the stomach. And there's still kind of a lack of long-term data, I will admit. This is a study out of New York, Reem Sharai, who's been doing it for quite a while, who shows some fairly durable results. I think that, in our case, because of the suture patterns changing a lot, for us to look at the 5-year data now will be a little bit skewed, because the suture patterns that we started using just over 5 years ago were much, less durable than what they are now. But I can just tell you, when we're looking at 3-year data, it's looking pretty good. It's looking similar to weight loss surgery. There are definitely patients who have weight regain. It probably will be somewhere around what a lap sleeve is, if not a little bit more. But it's still, it's not the majority of patients. And for that reason, I'm very excited about the procedure. It's also, it doesn't burn a bridge. I've converted a couple people who didn't have adequate weight loss or had weight regain. I've converted people with both laparoscopic sleeves and a gastric bypass. There were no issues at all. Most of the time, if you think about it, if the patient is having weight regain, probably they haven't, the sutures either broke free early, and we didn't have that kind of scar that I showed you on that previous picture. And so you have a straight line to staple, just like you normally would for a sleeve. And again, the bypass, the pouch is so small and away from the fundus that it's usually not, not an issue at all. And so, speaking of bridges, I do want to talk about this because I do think it exemplifies things. So as I mentioned earlier, we have laparoscopic surgery. We have a very low morbidity rate. but only 1% of eligible patients in this country are having weight loss surgery. So 1% of eligible patients in the United States are actually having weight loss surgery. It's a very low number. So the Choluteca Bridge is a bridge that in Honduras, and if you haven't heard about it, basically back in the 80s, the U.S. Army Corps of Engineers helped Honduras because they are prone to hurricanes that wipe out the bridges in the country. And it's very important for their economy that the bridges be intact, because when the bridges go out, a lot of their transportation is through trucks and others. And so their economy would basically shut down after hurricane season. And it was a big problem. So the U.S. Corps of Army Engineers basically wanted to develop a bridge that would stand even the strongest hurricane. And so indeed, they built this bridge, the Choluteca Bridge. And Hurricane Mitch, if you remember, which was in 1998, I believe, came through and actually wiped out every bridge in the country except for the Choluteca Bridge. So it actually did its job. The problem was that Hurricane Mitch, which was a Category 5 hurricane, was so strong that it actually moved the rivers, or moved the river underneath the bridge. And so the bridge survived, but the environment changed. And I feel like this is where we are right now. So patients we're really good. The Choluteca Bridge is our laparoscopic procedures. We're very good at minimally invasive surgery right now, whether it be colectomies for cancer, whether it be bariatric surgeries, I told you, with a very low complication rate. But the environment has changed. Patients don't want that. So we have a 2% morbidity rate with gastric bypass, but people don't want it. Patients want, and primary care and referring physicians want less. They want a less invasive procedure, even less invasive than laparoscopy. And so I urge the residents, students that are considering surgery, the endoscope is important. We're kind of at this crossroads that vascular surgery was maybe when I was a resident. When I was a resident, vascular surgery started doing interventional type techniques, and now obviously it's commonplace. Cardiac went through this even decades before that. And GI surgery, now we are at that crossroads. And I think that what vascular has done very well is made sure that they adopt the new less invasive techniques. And they're working very well with IR. And so you have a situation where you have IR and vascular both able to do procedures that are best for the patient. And I think that that's where we are. I can tell you just again, the patients are showing it to us. These are our consults since 2013, so over 10 years. Basically, we were hovering around 400. We started doing endoscopic sleeve in 2016, but again, no insurance coverage. This was cash pay. We were probably doing like 5 to 10 a year. These were patients that could afford it. It was highly experimental. We didn't know what the results were going to be. The randomized control, the MERIT trial that I showed you got published, and we started to understand how to do the procedure well, get good durability. And all of a sudden now patients have heard about it. And we've seen, without doing anything differently, we've seen a change. I mean, we don't have new surgeons or anything like that that have increased that. It was really the one factor that we can point to is the endoscopic sleeve has really made a difference. We've doubled our consults, actually. And I will tell you that the most common bariatric consult I get is endoscopic sleeve. Probably 80% of the people that walk in my door want an endoscopic sleeve. Now, through that, I don't want to focus only on bariatrics. There are other procedures out there that we're now doing endoscopically. This is actually a patient with achalasia and a dilated esophagus, as you can see. Had a myotomy. You'll see here that the lower esophageal sphincter is wide open, but there's a sump here. This is a patient with a dilated, tortuous, S-shaped, sigmoid-shaped esophagus, and food and liquid is really kind of sitting there. It's not even getting to the wide open LES after his myotomy. And this patient was in and out of the hospital, 87 years old. He actually is a father-in-law of our vice chair of research for the whole system. And in and out of the hospital with bleeds. He's actually ulcerating his esophagus. And we did not have a good option for him because he was not going to survive an esophagectomy. And so we did what's called a per-oral plication of the esophagus, where we basically did similar to an endoscopic sleeve. We just basically sutured that sump area straight, and we straightened the esophagus. He went home the next day. He didn't even need to spend the night. We don't keep people overnight anymore, but he was one of our first patients, and so we watched him overnight. And he never had to come back to the hospital again. We've been using this both for those of you that do esophagectomies, sometimes you get a gastric remnant up in the chest that gets kind of dilated and it's hard to empty. So we've been using it for that as well as achalasia. We haven't had to do an esophagectomy, since we started doing this procedure. It's been really a game changer for those patients. Those of you who do esophagectomies for achalasia or benign disease know that that's a very difficult procedure to do. And so we now endoscopically, with that suturing device, we've been able to close fistulas, leaks. We can suture stents. We can close mucosa when we're, purposely opening it up. Perforations, I've been called multiple times to the GI lab for acute perforations that we just avoided surgery. Watched the patient overnight. The patient did well. The GI physician was happy. Patient obviously avoided a surgery. They're happy, so then I'm happy. And so there are a lot of different options for this device. This is actually one of those perforations. This is a patient who's having an ERCP and the opposite side of the duodenal wall away from the ampulla perforated. And you can see we're going through there right now. And we're into the abdomen, familiar place for us. It's upside down. That's the abdominal wall now to the left. We actually put a Varus needle in here just because it was filling up and there was no way for it to escape. Like when we do laparoscopic surgery, your ports allow the CO2 insufflation to escape. Here, there's no easy way for that to escape. So you'll see us kind of put a Varus needle in there and evacuate that. I don't know if I can, don't need to show you the whole video. There's the Varus needle in there. So now we have an opportunity to work on this perforation. And we just used that suturing device that I showed you earlier, and we just basically sutured it. At that time, there was absorbable suture. Here we are coming down through the oral pharynx. You saw the ET tube there. We're going to get into the esophagus here, down into the stomach, and then we're going to come up to the perforation. And just like in surgery, we just did a couple of figure of eights and closed it. One little pointer, if someone's going to go off and do this, is that the first bite is actually the hardest because you're losing insufflation, so you can't really see very well at the beginning, as you'll see here. But as we start to close it, as the whole starts to come together, now we can insufflate the stomach and duodenum well, and you start to see better and better. So don't give up. If you can get that first stitch in there, it really makes a big difference. And then after that, you can really see much better. So again, we can do this in the colon. We can do this in the duodenum, as you can see. The stomach is even easier because it's a large, space within the organ there. Again, the perforation is kind of up and to our left, and we're just taking a bite there. I'm not going to go through the whole thing, but just we basically treated her kind of like closing an ulcer. We left an NG tube in overnight. We got a contrast study the next day. It was totally normal, and we took the NG tube out, fed her, and she went home. I'm going to have to exit out of here. I don't know if I'm going to be able to see here. Oh, I'm not going to be able to show you this. Okay, that's fine. So this is a new anti-reflux procedure. Basically, what we do is, the video is not going to play, but basically what we do is what's called an EMR. And we go, I don't know if I escape here, can we show my screen right now? Is there a way to do that or no? Yeah, like my screen out of play mode, because for some reason it won't play in the play mode. Oh, okay, that's fine, that's fine. So unfortunately, I can't show you the procedure, but it's just very simple. We basically just go in and we resect just the mucosa around the cardia. And so I can show you here. So the patients here in the left column, these are all pre-op patients. You can see valves that are fairly loose. We go in, we resect in retroflexion, just the mucosa around the GE junction. And so you're looking down here, for example, in the bottom middle, you're seeing just submucosa there. And then after a few weeks to months, when we come back, we see basically a significant difference in the tightness of that LES, or I should say the distensibility. And when it's called anti-reflux mucosectomy. It was actually developed by the same Japanese surgeon that developed POEM, if you've heard of POEM for achalasia, which I'll show you a little bit. When we look at patients who would have qualified for an arms procedure that had a Nissen, we actually see, significant change in OR time, much less length of stay. We send all these patients home. They have zero pain, no pain medications. They go home, they go to work the next day. And we see basically similar results in their reported quality of life indices. So again, this is a non-invasive procedure. And we thought this was a pretty simple thing, right? If you think about reflux like Newton's law of motion, where the flow of reflux through up into the esophagus is directly proportional to the pressure difference between the chest and the abdomen, but most importantly, the diameter of the esophagogastric junction opening by 4. Okay, so that's the most important thing. When we do an arms procedure, we thought, well, we're just simply kind of tightening that through scarring. We're tightening that, making it less distensible, and that's why we're seeing an improvement in reflux. But it actually might even be more than that. When we look at specimens from those resected areas of mucosa, this is an endoscopic mucosal resection. And when the depth of that is such that you can see those ganglion cells, we're actually getting some nerves in those specimens. And could that be an important aspect of this? Well, it might be. When we think about lower esophageal sphincter relaxation, a lot of it is triggered through basically tension receptors that then stimulate the vagal nerve to then open. And patients that have reflux that don't have a large hiatal hernia tend to have more of these inappropriate transient lower esophageal sphincter relaxation than patients who don't have reflux. And so it might be similar to AFib, where we're kind of interrupting these pathways by resecting that mucosa and into the submucosa of that area. So we might actually be not just scarring that area, but also making it not relax inappropriately. And this is just a study that was done that showed that when you look at patients that have a hiatal hernia, their reflux events are not necessarily transient lower esophageal sphincter relaxations. Whereas if you look at patients that have reflux without a hiatal hernia, the majority of the reflux events are going to be those transient lower esophageal sphincter relaxations. So this procedure doesn't fix a hiatal hernia, obviously. We're on the inside, but those patients that come in that have reflux and a hernia less than 2 centimeters, this is our go-to right now. This is our first line for those patients. And again, doesn't burn a bridge. If it doesn't work, we can always come back and do a fundoplication. But it's a very easy, low-risk procedure with almost a 0 complication rate. Really, it's just the anesthetic that's the complication potential. And there are other people that have looked at this. So this was done in a canine model, where basically our radio frequency energy was delivered to that same area that I was just discussing, just on the GE junction, the cardia side, just on the distal side of the GE junction. And what they found if you do ambulatory manometry, you can actually measure lower esophageal sphincter relaxations, and they actually showed a significant decrease. So there might be something more than just narrowing that area. I talked about POEM before. We've been doing POEM since 2012. This is our first line again for achalasia. This is a very simple procedure. Again, typically will take about an hour or less. We're going to make an incision in the mucosa. We're going to go into the submucosal area, as you're going to see, and we're basically going to develop that plane and then just do a myotomy. Laparoscopic Heller myotomies now are probably 10% of our achalasia patients, and we usually are reserving that for that rare patient that has achalasia and a hiatal hernia. Because if you do a POEM with a patient with a hiatal hernia, almost 100% of the time they're going to get reflux. I really think you need to treat the hernia. But in most patients don't have a hiatal hernia, POEM is our first line. We do give patients a choice. There are very few patients who opt for a more invasive procedure. They like the idea of a endoscopic, outpatient procedure, home same day. You can see here, we're just confirming on the stomach side that we're actually onto the stomach. We use the same principles as a laparoscopic Heller myotomy. You need a complete myotomy, both just proximal and just distal to the lower esophageal sphincter. And we're seeing results with POEM that are very similar to laparoscopic Heller myotomy. Basically, over 90% of patients have a clinical score, an Eckhart score, which is a clinical scoring system that looks at dysphagia, chest pain, regurgitation, and weight loss. 90% of people are in remission, even out to 4 years. And then this same kind of technique can be applied for gastroparesis. So I know Jim's in the audience. This is we do a combination of both gastric pacemakers as well as GPOEM or per oral pyloromyotomy is what probably surgeons say more often. And it's the same principle. We're going to make an incision in the mucosa. proximal to the pylorus, and we're going to tunnel so that where our incision in the mucosa is not over where our myotomy is. And this is, again, a procedure that has a very low risk and actually similar success rates to a pyloroplasty, which if you deal at all with gastroparesis, you know that even if you resect the stomach, patients are still symptomatic sometimes. So, we're not seeing over 90% success with this, but we aren't seeing that with anything really with gastroparesis. But we are seeing similar success rates to surgery. And again, this is an outpatient procedure. A lot of patients that have like POTS, for example, are very difficult to deal with. They have, very kind of low thresholds for pain. So doing an endoscopic procedure for those patients is much, much better, in my opinion, than any kind of surgery. We even do this for Zencker. This is actually my favorite surgery. It takes a very short amount of time. These patients are typically elderly. They're not great risk candidates, and we can avoid incisions. We don't have to use a rigid stapler anymore. I haven't touched a stapler for Zenckers in probably since before 2010, but you can see there's the cricopharyngeus right there. The diverticulum is on the left side, right there. You can see maybe some medication that's dissolving there. And then on the right side, you don't see it very well, but that's the true lumen of the esophagus there on the right. And we're basically just going to make an incision right over the mucosa, and using similar techniques to what you've seen, we're going to tunnel down on either side of the muscle, and then we're going to do a cricomyotomy or a cricopharyngeal myotomy. This procedure typically takes less than 30 minutes. And again, we're getting these mid-octogenarians home same day with a very minimal complication rate. And the reason that it's one of my favorite procedures is because these patients tend to come in very symptomatic, and they tend to leave without symptoms or very minimally symptomatic. And it's a very, the patients are very grateful when you can't defecate or you can't eat. It's a very troubling thing for a patient if you haven't seen that already. And so having somebody that can now swallow better they're typically very grateful, and then I'm very happy. So again, using the same principles of kind of tunneling and cutting muscle. And you can see here, that's actually the esophageal wall. There's circular and longitudinal muscle right there. We're just going to come a little bit onto the wall there just to make sure that we have a full myotomy. So you can see the longitudinal muscles splayed here on the left, and those are the circular muscles of the esophagus. So we're onto the esophagus. We've completely transected the cricopharyngeus, which, previous endoscopic procedures, we'd be a little bit nervous about going all the way through like that. But here, because we know that we can get secure closure with the modern instruments and modern clips that they have, we're not afraid to go all the way down. So now you can actually already see the lumen opening up on the right there, diverticulum still on the left. And interestingly, as long as the diverticulum is not over 4 centimeters, it almost always will resolve over a few months. But more importantly, their symptoms are gone right away, even when that mucosal diverticulum exists, because most of the dysphagia is coming from the muscle not relaxing. It's not from the actual diverticulum itself. So I think that what we're seeing, as I mentioned before, we're seeing that patients want less and less invasive procedures. We're starting to see, as I mentioned before, I haven't done an esophagectomy for high-grade dysplasia, since I was a resident, actually. So now we can do esophageal, we can do ablation, radiofrequency ablation, we can do endoscopic mucosal resections, and that's our first line. So anybody with T1 disease or less, we're going to ablate them, or if they have nodular disease, we're going to resect that either with an EMR or an ESD, endoscopic submucosal dissection. Heller myotomy, as I mentioned before, now we're, less than 10% of our myotomies are, and we do about 75 poems a year, and we probably do about 5 laparoscopic Hellers a year now. Fundoplication, I think that, we're not completely in danger of completely losing that procedure, because there's no question that the crura still needs to be repaired, and we don't have an endoscopic method to repair the hiatus right now. But for patients that don't have a hiatal hernia, or at least one that's over 2 centimeters, an endoscopic approach is, again, preferable in my opinion. Obviously, endoscopic mucosal resections for early cancers in the colon and rectum as well. As I mentioned, bariatric surgery, we're doing endoluminal, endoscopic suturing and stenting for perforations, as I showed you. And now there's even, maybe you guys are doing it here, but now there's even, fistulas that are being created between the gallbladder and duodenum. we're not doing that just yet. I think that there are some things that need to be worked out with that procedure. But the bottom line, though, is that, this is a cardiac surgeon that just said this actually in September. But in time, I predict that cardiac surgery as we know it today will become largely obsolete. In a way, much of today's surgery is a pretty gross intervention as it causes trauma to the patient in the process of achieving access to the area of surgical endeavor. And so this is not just for GI surgery. This is all of the specialties. Obviously, cardiac surgery has gone through this before. They're doing valves now. Even mitral valves are being done percutaneously. So we're seeing this shift in every specialty. And I will say that for me, it hits home too. This is my family, my wife, Renee, my daughter, Sophia, and my son, Anthony. This is the day after my wife came home from an 8-day stay in the ICU. Out of the blue on October 25th of last year, she ruptured a cerebral aneurysm. And we had no idea. She's a completely healthy person. We had no idea she had an aneurysm, but my son probably saved her life. I was actually at University of Chicago giving a talk to the residents. They were getting ready to go to school. It was a Wednesday. It happened to be a late day for them, which was maybe fortunate. So it was about 8:30 in the morning. And my wife started having mental status changes along with a severe headache. And my son called 911. They took her to the hospital. She, again, was treated. When I was a resident, I had to do neurosurgery as an intern. When people came in with a ruptured aneurysm, we had to do a craniotomy. And the patients certainly didn't leave the hospital the same way they came in terms of their mental status. But things are different now. They went through her ulnar artery, they embolized her aneurysm, and then they stented the area. And she was fine that afternoon. As a matter of fact, the next day when I came to see her in the ICU, I knew she was okay because she said to me, I said, "How are you doing?" And she said, "Well, it's really kind of a nuisance here because they have an alarm on my bed and I can't get up to go to the bathroom without calling somebody. They don't want me to get up alone." But she said, and she said, "They don't come. Like when I call the nurse, they don't come right away, but I figured something out. Watch this." And she started to get out of bed and the alarms went off and all the nurses came running in. So I knew she was okay because that's how she is. So she figured it out right away. But we had to stay in the ICU for 8 days just for monitoring because apparently as the blood, resolves in the brain, people are at risk for vasospasm and CVA. And so we were there, but she was fine from day one. And again, so I saw the benefits compared to what I used to have to go through or saw with craniotomies and aneurysm clipping. My own wife was treated in a non-invasive way, and we're forever grateful. She has 0 deficits. The only deficit she has, she doesn't remember that day. She doesn't remember the day that it happened, but she has no neurological deficits otherwise. The only thing she was complaining about the next day was her wrist, that her wrist hurt. And I was like, "You have no idea. Just take it. Just take it." So anyway, I hope that I've been able to convince you that, especially for the trainees in the room and online, that you need to make sure that you get an endoscope in your hand if you're thinking about GI surgery, because that's where we're going and you need to know it. You need to be able to offer it. I think that we're going to be in a space similar to vascular surgery and IR where we're going to be living with GI, and there's no problem with that at all. There's some really good GIs out there that do some really good endoscopic surgery, and there are a lot of GIs that don't want to have anything to do with, making perforations in people or suturing or any of that. But I think that we're going to live together in that space, and we need to. If we don't, they will. I guarantee it. I mean, there is a lot of interest in the endoluminal bariatric surgery, but you know what? Bariatrics is something that surgeons have been doing for decades. And that's a specialty that we should not ever, give up, because I think we've learned a lot over the decades of how to treat those patients. We just need to make sure that we're not stuck in our ways and that we learn new procedures and we make things better for the patient. So I'm happy to answer any questions. I really appreciate the opportunity to come here. It's been a wonderful trip. Thank you very much.